بسم الله الرحمن الرحيم. Assalamu alaikum everybody. Wishing you a happy new year with the hope that you will have many blessings from Allah subhanahu wa ta'ala in the years to come. This is a continuation of my last presentation about inhalation general anesthetic. In the last presentation, we talked about different types of anesthetics, their mechanism of action, and we talked about the stages of general anesthesia. What are the factors that will affect induction phase of general anesthesia? We talked about a property of an ideal general anesthetic and as well the drugs which are used either before or during or after general anesthesia. The main goal is to compare between the different properties of inhalation anesthetics in terms of their physical properties and their specific unique pharmacokinetic property, and as well in their pharmacodynamic property, including their action on the central nervous system, cardiovascular system, renal system, and the respiratory system. Lastly, we'll talk about the specific drug-drug interaction and adverse drug reaction of inhalation general anesthetics, and as well about their clinical applications. So, as we have said last time presentation, that the general anesthesia is achieved by administration of the inhalation general anesthetic through the respiratory tract, and this will produce an induction, what we call induction phase, and this induction will lead to the general anesthesia, and this is what we want, is the general anesthesia, a reversible loss of consciousness. And once we stop the general anesthesia, recovery will take place. We have said that the induction should be as fast as possible, should be pleasant induction. It doesn't produce excitement or whatever. And also we have said that general anesthesia should be maintained for long enough time to permit the surgery. Also we have said that the recovery should be fast. So this is the main goal of general anesthesia, is to produce loss of consciousness and loss of pain sensation that permits surgery. Now, all this will depend on the property of general anesthetic and of course on the use of mixture of drugs. So what are the differences in the properties of different inhalation anesthetics? We start first with their differences in physical property. This is very important, as we will see later. The physical property, as we have said, they differ in nature. For inhalation anesthetic, they might be a volatile liquid, and we have said that they are present as a volatile liquid at room temperature, or they might be a gas. They are filled in cylinders. They are present as a gas in room temperature. For the volatile liquid anesthetics, we have two different groups, some which are like alcohol, which is the ether, as we will speak now, and some of them they are known as halogenated hydrocarbons. Halogenated hydrocarbons means that they have a halogen like fluoride in their structure. Examples include many. For example, ether is an alcohol ether. Ether is an old anesthetic, is the oldest anesthetic induced into medical practice, and now its use is limited to third world country. Although ether is very good general anesthetic. Why? Because it has a wide margin of safety. It has a wide margin of safety. But ether is not used anymore because of two reasons. First, it is explosive. It is explosive nature. That means it can cause explosion with modern anesthetic machines because of any electrical spark or whatever, it can cause explosion. That's why ether is not used. But if open system is used, ether is still used in the third world country. Other disadvantage of ether, that's why it's not used anymore in modern anesthesia, is that it causes irritation of the respiratory tract because of its pungent odor. It causes irritation of the respiratory tract, and these can cause laryngospasm. can cause laryngospasm. But this can be avoided by giving atropine, as we have said last time, okay? The second is methoxyfluorine, which is a halogenated hydrocarbon, methoxyfluorine. Methoxyfluorine as well, it's not used anymore in surgical anesthesia. Why? Because it is toxic to the kidney, as you will see later. It is nephrotoxicity. It causes nephrotoxicity. ولكن methoxyfluorine is still used in some ambulatory conditions where analgesia is needed because it is very good, strong analgesic, as you will see later. Okay, methoxyfluorine, its use is very limited and it is not used anymore because of its renal toxicity. Okay, but why we are mentioning them here in this sequence? Because we want to make comparison. We want to make comparison between the different property and the different actions. The oldest halogenated hydrocarbon which is still in use, especially with pediatrics, is halothane. And halothane as well, its use is very limited nowadays. Why? As we will see later, because it is toxic to the liver. It produces liver toxicity, as we will see later. الأذر الإنفلورين والأيزوفلورين والسيفوفلورين والديسفلورين إنفلورين أيزوفلورين سيفوفلورين disflurane. These are the new inhalation halogenated hydrocarbons which are in common use in surgery. Okay, يبدأ these are the volatile liquid anesthetic. The volatile liquid anesthetics concludes halogenated and non-halogenated. The non-halogenated, the only example is ether. Well, ether, as we have said, it is only used in the third world country. It's not used with modern surgery or modern anesthetic machines. Okay. Another class اللي هو الجاز, gaseous anesthesia, gas which are present, they are anesthetic which are present as a gas at room temperature. And we have two famous examples. We have two famous examples, nitrous oxide and the xenon. Nitrous oxide and the xenon. We have to pick to be careful. This is nitrous oxide. This is not nitric oxide, the known second messenger. It is completely different. This is nitrous oxide. Nitrous oxide. So, how they differ from each other? These general anesthetics, some of them, as I have said, still in clinical use. Some of them, they are outdated. So what's how they differ? They differ in many properties. لكن I will take only three major properties which are important for us. The first is the blood gas partition coefficient. Blood gas partition coefficient. For blood gas partition coefficient, we said it indicates the solubility of the general anesthetic in blood. فقلنا the higher the blood gas partition coefficient, the higher the blood solubility. And we have explained in our last presentation how this will affect induction phase. فقلنا the higher the solubility, the longer the induction. وقلنا كذلك, and we said as well, that lower blood solubility produces faster induction. Okay. The second is the oil-water partition coefficient, which indicates the solubility of the general anesthetic in oil, which is in lipid. The lipid solubility of the general anesthetic. وهذه it means that if it is high, it has high lipid solubility, it will have two different consequences. The first, in that it will be distributed to most tissues in the body. The second, that it will be metabolized, because the lipid soluble, as we have said, they have to be metabolized to polar compounds. A third property is the MAC value which called minimum alveolar concentration. وفي الماك value we said that this indicates potency. The lowest the MAC value, the more potent is the anesthetic, the percentage we needed to produce a general anesthesia. Okay, so now we start with comparison between the blood gas partition coefficient, as we have said. As you can see, ether and methoxyfluorine, both of them, they have high blood gas partition coefficient. High blood gas partition coefficient. What does it mean? It means that ether والmethoxyfluorine will produce long induction. If they are used alone, they produce long induction. Why? Because the blood like this anesthetic. So what will happen? The rise of partial pressure will be slow. It will take long time before the blood becomes saturated with the anesthetic, and the anesthetic will be transferred to brain. We have explained that in last presentation. If you cannot follow me now, please refer to my last presentation. I explained that in details. Okay. So now, so ether and methoxyfluorine, they produce long induction. Why? Because they have high blood solubility. In others, الهالوثين, الانفلورين, الisoflurane, they have moderate blood solubility, as you can see. They have moderate blood solubility. With the lowest blood solubility are sevoflurane and disflurane, 0.65 and 0.45. Sevoflurane and disflurane. Therefore, sevoflurane and disflurane will produce the fastest induction phase. So if anybody asks you why sevoflurane produce faster induction than halothane, why? Because the sevoflurane has a lower blood solubility, so that the rise in partial pressure in blood will be very fast. Okay, so these are for the halogenated or volatile liquid anesthetic. For the gaseous anesthetic, nitrous oxide, it has a low blood solubility, and still lower is the xenon. Xenon, it has very low blood solubility, as you can see, very low. Yani once it reaches the blood, the rise of partial pressure will be so fast that it will be transferred immediately into the brain. That means xenon will produce the fastest induction. Yani within seconds, it will enter the brain. Xenon will produce the fastest general anesthesia. Okay. يبقى this is first اللي هو blood gas partition coefficient. Second property is the oil water partition coefficient, and this we said it indicates lipid solubility. As you can see, the highest lipid solubility is methoxyfluorine. It has very high lipid solubility. Halothane as well, it has a high lipid solubility. This high lipid solubility of methoxyfluorine, it means that methoxyfluorine can be distributed all over the body tissue. In that case, what will happen after we stop the anesthesia? معناها tissue will act as a reservoir. It will release methoxyfluorine slowly, and this will prolong recovery. This is one. والسكند ان stored methoxyfluorine will be metabolized to fluoride, and this will be toxic to the kidney. That's one of the reasons why methoxyfluorine is not used anymore. Why? Because it has high blood solubility and as well high lipid solubility, and it is metabolized in the liver into a toxic fluoride ions. Okay. The others, they are moderate in their oil blood solubility. With the lowest, we can see here with the nitrous oxide. With the nitrous oxide and xenon, they have the lowest lipid solubility. They have the lowest lipid solubility. Okay. The third property we are going to discuss is their difference in the MAG value. Well, MAG, we have said it indicates minimum alveolar concentration. It indicates the potency of the general anesthetic. The lower the MAG value, the highest is the potency. As you can see, the highest potency of all these is methoxyfluorine. Methoxyfluorine, although it is highly lipid soluble, highly blood soluble, still it is very potent. We need only 0.16% to produce loss of consciousness. This is followed by halothane and so on. By halothane, and next is the influrane, then isoflurane, sevoflurane, and the lowest potent of the halogenated hydrocarbon is disflurane. As you can see, disflurane, it has the highest MAG value. Madam, highest MAG value, manad, it is the least potent. We need 6% of it to produce general anesthesia. ولكن generally, all the halogenated hydrocarbons, they have a good potency. They have a good potency. The lowest potency with gases, as you can see, with nitrous oxide. we need more than 100% of nitrous oxide to produce loss of consciousness. Actually, nitrous oxide can never produce loss of consciousness. Why? Because we need 100%. If we use 100% of nitrous oxide with no oxygen, hypoxia will take place and the person will die before he can lose consciousness. Therefore, nitrous oxide, many people, they call it the inhalation general analgesic, not anesthetic. Why? Because it does not produce complete loss of consciousness. فبالتالي nitrous oxide alone is not good ولا is cannot produce loss of consciousness, وبالتالي it is usually used with other general anesthetic. So in this case we use, for example, 60% of nitrous oxide together with mixed with 40% of oxygen and accompanied by other halogenated hydrocarbon. In this case, nitrous oxide can decrease the dose needed from the other halogenated hydrocarbons, as I have explained in the previous presentation. Xenon, on the other hand, it has a low potency, about 70% we need to produce loss of consciousness. With 70% is good enough because we can mix 70% of xenon with 30% of oxygen. 30% is enough to give oxygen for all body tissue. Therefore, for the oxygenation of different tissues in the body. Therefore, xenon is good to be, it can be used alone as a general anesthetic because it can produce loss of consciousness at 70% mixed with 30% pure oxygen. Okay? So these are the properties of the general inhalation general anesthetic. These are the properties of the inhalation general anesthetic. Somebody might ask why we are studying physical property. Because the physical property will decide the pharmacokinetic and the pharmacodynamic property as well, okay, as you will see later. Because these physical properties which we have discussed and we compared between each of the inhalation general anesthetic, it is very important in deciding the pharmacokinetic and the pharmacodynamic property of the general anesthetic. How this is done? So second, we are going to discuss is the difference in the pharmacokinetic property of the general anesthetic. As we have said before, the pharmacokinetic deals with the absorption and distribution of the drug, and after the drug produces its action, the body would eliminate it through the process of elimination. So now we are going to discuss what's the difference between the absorption and distribution of the inhalation general anesthetic. Generally, as we have said, in the movement of the ion distribution of any drug from one compartment to the other will depend on the concentration of the anesthetic in the previous compartment, as we will see now. So first, the anesthetic will be present in the inspired air. This is first, because we are giving it is inhalation anesthetic, so we are giving it through the inspired air, mixed with the inspired air. Then it will be transferred into the alveolar air, into the alveoli, which is known as the end-tidal volume, okay? So in this case, we expect that the concentration in the alveoli will depend on the concentration of the anesthetic in inspired air. For example, if we give the inspired air only 1% or 2%, in this case, if we increase the percentage in the inspired air, the amount that will be reached in the alveolar air will be increased as well, okay? So this is one factor. The concentration in the alveolar air will depend on the concentration of the general anesthetic in the inspired air. Also, it will be affected by the minute volume or residual capacity. As we know, by increasing the minute volume, we will increase the volume of inspired air, and in this way we will increase the amount of the anesthetic delivered to the alveoli, okay? So concentration in the alveoli will depend on the concentration of the anesthetic in the inspired air and as well on the function of the respiration, like in minute volume or like a residual capacity. Okay. After the alveoli, the anesthetic will pass into the blood, So the amount that will reach the blood will depend on the amount of the anesthetic alveolar air, وكذلك as well it will depend on its blood solubility, blood gas partition coefficient. فكل ما blood gas partition coefficient يكون high معناها solubility of the anesthetic in the blood will be high. So the amount of the anesthetic in the blood, distribution of the anesthetic in the blood will depend on the alveolar concentration, alveolar permeability. Of course, كل ما permeability increases, كل ما amount transferred will be more, and as well on the blood gas partition coefficient. So we can see here in a blood gas partition coefficient will affect the amount of the general anesthetic that can reach the blood. Okay. Then from the blood the general anesthetic will enter the tissue including the brain اللي يهمنا البرين اللي هو site of action. فبالتالي the amount of the anesthetic that will reach the brain will depend on the amount of the anesthetic in the blood and the rise of the partial pressure of the anesthetic in the blood, and as well it will depend on the oil gas partition coefficient, which is the lipid solubility of the anesthetic in the lipid solubility of the anesthetic. Okay, the higher the lipid solubility the higher will be the distribution to the brain. واضح كلام؟ Okay. يبقى these are absorption and distribution. The amount that can be distributed will depend on different factors like respiratory volume, like blood gas partition coefficient, like oil gas partition coefficient. Of course, the concentration that will reach the brain will determine the depth of the anesthesia. The depth of anesthesia will depend on the concentration of the anesthetic in the brain, of course, لأن this is the site of action. Okay. Now this is how different properties of the general anesthetic will affect its distribution, as we have said, and this will affect as well the induction phase or recovery phase. Okay. Now after the drug is distributed, produce its action, the action will be terminated as well. Termination of the action is done through elimination. Well, elimination, as we have explained before, it contains two different phases, metabolism and excretion. Metabolism, we have said, it takes place for lipid-soluble molecules. All lipid-soluble molecules will be metabolized into water-soluble molecules that can be excreted through the kidney or through other routes of excretion. Now we know that elimination of the general anesthetic will depend on metabolism and excretion. طبعا metabolism, as we have said, takes place in the liver. Metabolism takes place in the liver by hepatic metabolism. This is done only for the lipid soluble. Any molecule which is not lipid soluble, it will be excreted immediately. It will not be metabolized. فالhepatic metabolism takes place to the anesthetic with lipid solubility. They differ in their hepatic metabolism. For some of them, they are minimally metabolized in the liver, minimal metabolism. In this case, their elimination will not depend on their elimination will not depend on liver function minimum metabolism. وهذا includes isoflurane ودisflurane, nitrous oxide, and the xenon. Nitrous oxide with xenon, they are not metabolized at all in the liver. They are excreted as they are. Okay. This is the first difference. Some of them, they are minimally metabolized in the liver, therefore they will have no problem with liver diseases. Some of them, they are moderately metabolized in the liver. For example, sevoflurane, about 5% will be metabolized in the liver. Some of them, like halotane, 20% of halotane is metabolized in the liver. Methoxyflurane, I didn't mention that here. Methoxyflurane, 70%, 70, not 20, 70% extensively metabolized in the liver. Methoxyflurane is extensively metabolized in the liver. That's why methoxyflurane is not used anymore in surgery. Why? Because it will be metabolized to fluoride ions. All fluoride, as we know, is highly toxic to the kidney, and this will result in renal failure. That's why methoxyfluorine is not used anymore. واضح الكلام؟ الهالوتين still produces some fluoride ولكن not high level وهكذا. المهم what I should know in this case إن elimination is done through metabolism of drugs which have high lipid solubility, for example methoxyfluorine, for halothane to certain degree, and with minimal with other drugs. ما دام هادو minimal معناها they don't produce fluoride which is toxic to the kidney. Okay. Now now once the metabolism takes place, it is excreted in the kidney. Usually metabolites, whether they are organic or inorganic fluoride, metabolites usually it is excreted through the kidney. It is eliminated through the kidney. واضح كلام؟ يحصل metabolism والفلورايد will be excreted through the kidney. والrest of all volatile general anesthetics, they are excreted through the lungs. They are excreted through the lungs. يعني in the expired air. They are excreted in the expired air. Most agent, most general anesthetic, they are excreted now under clinical use. Most of it, they are excreted through the expired gases. يعني once I stop giving the general anesthetic, immediately what is left in the body will be eliminated through the expired air. Okay. Now, this is the differences in the pharmacokinetic property. They differ, as we have said, in the absorption, distribution, according to different factors, different physical properties, as we have explained, and they differ in their elimination according to their lipid solubility. واضح الكلام؟ Okay. Now, they differ as well in their pharmacodynamic property. Pharmacodynamic, we call them their mechanism of action and their pharmacological action. They differ in the mechanism of action, as we have explained in the last presentation, and as well they differ in their action on different organs in the body. On the central nervous system, of course, all of them, they produce dose-dependent inhibition of the central nervous system. Usually this is descending inhibition. What does it mean, descending inhibition? Means they start from the upper parts of the central nervous system and it goes down the brain, as we have explained last time. So first, they have qualitatively different effect on the central nervous system, and all of them, they produce dose-dependent descending inhibition of the central nervous system. Some of them, they have they increase cerebral blood flow. They increase the cerebral blood flow. طبعا because they produce vasodilatation. Vasodilatation طبعا of the cerebral blood vessels will result in increase the cerebral blood flow. This is sometimes in brain injury is not recommended. يعني we have to take care of these effect لأن لو في brain injury معناها cerebral blood flow will be increased, the chance of intracranial bleeding will be increased. ولكن this is to a certain degree. يعني it depends on the anesthetic used. كلهم they have no analgesic property except for methoxyfluorine, nitrous oxide, and the xenon, and xenon gas as well. Xenon, it has very good analgesic property. يبدأ nitrous oxide, xenon, and methoxyfluorine, they have very strong analgesic property. Others, they are devoid of any analgesic. Analgesic مسكن يعني. Analgesic is different from anesthetic. And analgesic action means they can prevent the pain sensation. Analgesic action, they can prevent pain sensation. pain الوجع. They can prevent the pain sensation. وجع. They can prevent the pain sensation. فبالتالي we expect that the general anesthetics, they are not good analgesics. Only some individuals of them, they have good analgesia, which is methoxyflurane, which is not used anymore for surgical anesthesia. And nitrous oxide is used, xenon is used. Okay. On the cardiovascular system, the same thing. They have quantitatively and qualitatively different actions on the cardiovascular system. So we expect that some of them they have a depressant effect on the cardiovascular system, and some of them they don't have any effect on the cardiovascular system. فبالتالي you will see that there is depression of cardiac contractility and conduction with, for example, halotene. Halotene will depress cardiac contractility. Well, halotene is known to produce cardiac arrhythmia, especially when they are used with adrenaline. فالهالوتين it is more prone, that's why its use now is very limited. One of the reasons that it can produce cardiac arrhythmia, especially when it is combined with adrenaline-like drugs, catecholamines. Okay. Sevoflurane, on the other hand, it depresses contractility and cardiac output when it is used in 1 mag value concentration. Sevoflurane is a depressant. Okay. The least effect on the cardiac contractility is desflurane and isoflurane. They have the least effect on the cardiovascular system. Okay. On the vascular smooth muscle, all of them they inhibit the contraction of the vascular smooth muscle. فبالتالي we expect that they can produce decrease in blood pressure. Like this reduction of blood pressure is not notable, it's not very strong. فبالتالي there is no worry about this action. يبقى they all agent they decrease the vascular smooth muscle tone of the muscle will be decreased, and this will result in vasodilation and decrease in blood pressure. That decrease is not that strong, it's not that strong. ولكن desflurane الopposite. Desflurane can increase the blood pressure. ليش؟ لأنها produce sympathetic stimulation. This is very characteristic للديسفلورين. Desflurane it can increase the blood pressure by activation of the sympathetic nervous system. As we have said, sympathetic nervous system activation will produce vasoconstriction, and this vasoconstriction will increase blood pressure. This happens usually when we rapidly increase the anesthetic concentration in the inspired air. يعني مثلا لو واحد كان يستعمله في 1% وزدناها ل 2% immediately fast increase, rapid increase. في الحالة هذه this fluorine can increase blood pressure. ولكن this is not very يعني very serious. It's not a disadvantage. Okay. Now, these are the actions on the central nervous system and the cardiovascular system. On the respiratory system, all of them طبعا they can cause dose-dependent depression of respiratory system, and this is effect usually it is a central effect because once they enter the brain they can cause mild depression of respiratory centers in the medulla, and this can cause respiratory depression. Safest way in this case in the patient is placed under artificial respiration. Okay. كلهم all of them they cause decrease in the tidal volume. معناها ما دام tidal volume is decreased معناها volume which can reach alveolar concentration will be decreased by time, of course. في some of them desflurane, this is the halogenated, methoxyflurane والether, because they have a pungent odor. They cause irritation of the respiratory tract. Irritation of the respiratory tract can result in laryngospasm. During surgery, which is a disadvantage. طبعا الإيثر زي ما قلنا it's not used anymore with the modern surgical machines, ولكن it's still used in third world country. Methoxyflurane is not used, and this fluorine is still used, ولكن in this case we can prevent the laryngospasm by giving atropine-like drugs. The laryngospasm can be prevented by giving atropine-like drugs. Sevoflurane characteristic because it is given through respiratory machines. Respiratory machines, they contain soda lime. Soda lime is to absorb carbon dioxide from from the air, from the mixture of air in the respiratory machine. فبالتالي السيبوفلورين chemically it interacts with soda lime and this is dangerous. So that's why the sevoflurane should never be used in anesthetic machines containing soda lime. Okay, you have the sevoflurane. We have to remember that the sevoflurane with soda lime. Soda lime is placed or put in the anesthetic machine to absorb with carbon dioxide. فبالتالي this will interaction will produce toxic metabolites. Should never be mixed. Should never be used in a machine containing soda lime. You have the neuromuscular action. All of them they inhibit the polysynaptic neuron, and this will result in muscle relaxation. The degree of muscle relaxation will depend on the dose, from moderate like Halogenated to good muscle relaxation like others, Influrane, with Sevoflurane, with Disflurane relaxation. ولكن in this case usually in common practice what they do they add the neuromuscular blockers which we talked about last presentation. Neuromuscular blockers. Why we add the neuromuscular blockers is to decrease the dose of general anesthetic needed to induce muscle relaxation. في الحالة هذه instead of working at late planes I work at earlier planes. واضح الكلام هذا؟ يبدأ although they produce good muscle relaxation لكن practice in the neuromuscular blockers are added to reduce the amount of the general anesthetic needed to induce loss of consciousness. Okay, now and muscle relaxation of course. On the uterus, all of them they produce relaxation of the uterus except for the ether and nitrous oxide and xenon. يبقى all of them they produce relaxation of the muscle of the uterus. This is not favorable in case of spontaneous delivery. In case of spontaneous delivery اللي هو vaginal delivery اللي هو normal labor. Normal labor is not advisable. These are a general anesthetic except the ether. Ether does not affect the uterine contraction. ولكن all others they produce relaxation of the uterus. معناها they will delay normal labor. They will delay normal labor. They are not used during normal labor, but they are used to relax the uterus in the cases of intrauterine manipulation of the fetus. Sometimes they open to make certain surgical procedure in the fetus while it is in the womb. Okay, so in this case they use these anesthetics because they produce good muscle relaxation of the uterus. Okay, واضح? Okay, يبقى this their effect on the uterus. On the liver, all of them they are safe on the liver except for halothane. Halothane is a toxic to the liver. They said that halothane produces two different types of toxicity. The one is known as type 1 toxicity. With type 1 toxicity, usually this is not an immune reaction. It is due to the metabolite of halothane. Metabolite of halothane, it is metabolized to toxic metabolite which cause injury to the liver. This will cause certain increase in the liver enzymes and so on. This will take place about 1 to 2 weeks after administration. This is known as type 1 hepatotoxicity. The hepatotoxicity type 1, it resembles symptoms of hepatitis and usually takes place within the first week of administration of halothane. Okay, halothane as well, it can produce more serious toxicity known as type 2 toxicity. Type 2 toxicity. For type 2 toxicity, this is an immune reaction. Immune reaction معناها in this case الميتابولايت of halothane will be considered as an antigen and the body will produce antibodies, and this antigen antibody reaction on the liver cells it could cause necrosis or death of the hepatic tissue, and this will end up with severe hepatic necrosis. With severe hepatic necrosis, as you know, is very dangerous. في الحالة هذه that's why Halothane nowadays is not preferable, especially in adults, and its use is limited only to pediatrics because they are less sensitive to the action of halothane. ولكن in this case we have to make sure ان the person is not exposed to halothane after the first exposure. يبدأ first exposure and then halothane should not be given again to the same patient. Okay. Sevoflurane on the other hand, sevoflurane on the other hand, it can sevoflurane is another anesthetic which is metabolized to the liver, metabolized into in the liver, and it can release fluoride, or this fluoride can induce renal toxicity. This fluoride can induce renal toxicity. Okay. Next, we are going to speak about the drug-drug interaction and adverse drug reactions of this group of drugs. First, drug-drug interaction. It is well known that halothane can increase the sensitivity of the heart to adrenaline, الكاتيكولامينز in general, like noradrenaline, adrenaline, dopamine, كلهم. فهالوتين can increase sensitivity of the heart to adrenaline. In some cases, sometimes, for example, when a person during surgery, they need to increase his blood pressure. Sometimes they use adrenaline, and adrenaline, as we know, it causes vasoconstriction. It will increase blood pressure. If we give adrenaline with halothane, the halothane will increase the sensitivity of the heart to adrenaline, and this will result in deadly or fatal cardiac arrhythmia. Cardiac arrhythmia. الانفلورين does the same لكن to less degree. Does the same. الانفلورين produces the same with less degree than halothane. فبالتالي الهالوثين or influrane mixture with adrenaline is completely contraindicated. Somebody might ask you why? Why? Because the halothane will sensitize or increase the sensitivity of the heart muscle to catecholamines. This will result in fatal cardiac arrhythmia. This combination is contraindicated. As for the adverse drug reaction, there is one adverse drug reaction which we should know very well, which is known as the malignant hyperthermia. Malignant hyperthermia. And from its name, malignant means severe increase in blood and body temperature. Malignant means severe increase in body temperature. Malignant hyperthermia, usually this is very rare, but it is fatal. If it happens, it can kill the patient, okay? And usually this is due to a defect, genetic. It is genetically determined. As we have spoken before, adverse drug reaction, usually it is a idiosyncratic reaction which happens due to a genetic differences. So usually what happens in there is genetic differences in the renoids receptors which are present on the sarcoplasmic reticulum. As we know, sarcoplasmic reticulum is the main store of calcium. Once the patient is given volatile anesthetic, what will happen? يحصل release of a huge amount of calcium from its store. A huge amount of calcium will be released. طبعا calcium will cause severe muscle contraction. معناها severe muscle contraction will result طبعا muscle ما دام contracted severely to produce heat. This heat will result in severe hyperthermia. Okay? يبدأ malignant hyperthermia is genetic defect in the renoids receptors which are present in the sarcoplasmic reticulum and responsible for the release of stored calcium. In this case, if we give the volatile anesthetic, يحصل release of large amount of calcium, and of course plus succinylcholine, the same thing. Succinylcholine will increase the amount of calcium released as well, because succinylcholine, as we have said, it acts as a partial agonist on nicotinic receptor, causing depolarization of the motor end plate with the release of calcium. This mixture usually they increase the effect of each other. So what will happen? Release of large amount of calcium. Calcium will cause severe contraction of the skeletal muscle. The severe contraction of the skeletal muscle will produce high energy, producing hyperthermia, severe hyperthermia. Severe hyperthermia will result in different things, including طبعا madam there is severe contraction معناها there is increase in oxygen consumption وكذلك increase in carbon dioxide production. فsevere hyperthermia is accompanied by increase in oxygen consumption and as well increase in carbon dioxide production. This is together with what's known as disseminated intravascular coagulation. The severe hypothermia can result as well in the يسموها disseminated intravascular coagulation, which is very bad. معنى coagulation intravascular, which is very bad. An increase in carbon dioxide production will increase in oxygen consumption, especially the production of carbon dioxide. This will result in what's known as metabolic and respiratory acidosis. Metabolic and respiratory acidosis. So as you can see, hyperthermia, general anesthetic, cause release of a huge amount of calcium due to genetic defect in the calcium stores. Calcium will cause severe contraction of the muscle, and the severe contraction of the muscle will result in severe hyperthermia. And body temperature can rise up to 42, 43 degrees centigrade, which is very dangerous. Muscle rigidity plus hyperthermia plus increase in oxygen consumption plus increase in production of carbon dioxide, which will result in metabolic acidosis. Metabolic respiratory acidosis, as you know, will affect all body organs. Okay. Severe hypothermia also, it will lead to muscle damage. This is known as rhabdomyolysis. Rhabdomyolysis معناها skeletal muscle will be damaged. بيحصل لها lysis معناها ذوبان. المسل will be lysed. يسموها rhabdomyolysis. Now this rhabdomyolysis معناها skeletal muscle will release its potassium in the blood. This will result in hyperkalemia. طبعا المسل will release its myoglobin, والmyoglobin will be excreted through the urine, producing myoglobinuria. Myoglobinuria, this is very dangerous. It can lead to acute renal failure. Okay? This is malignant hyperthermia. It is life-threatening. It is fatal if it happens, and should be stopped immediately. So if it happens, what we should do? طبعا اللوجيك يقول إنه we stop immediately inhalation anesthetic with depolarizing anesthetic. We stop depolarizing neuromuscular blockers, succinylcholine, and inhalation anesthetic. We increase the minute volume to increase the expiration of carbon dioxide, and mostly اللي يهمنا احنا كفارماكولوجي is the administration of dantrolene. Dantrolene, this is a drug which will, the only drug which is effective in malignant hyperthermia. What it does do, it inhibits the calcium channels on the sarcoplasmic reticulum, and therefore it will decrease the calcium release. It will decrease the release of intracellular calcium. You have that? So dantrolene, by preventing the release of calcium, it will decrease the muscle contraction. فبالتالي it will decrease contraction of the muscle. Okay. Now, and other measures, there are other measures. So what they do, cooling measures, they give either intravenous normal saline at 4 degrees centigrade and use of ice bags. They manage arrhythmia if it is present, as we have said, can be prevented by amiodarone and lidocaine. Lidocaine is local anesthetic, while amiodarone is calcium channel blocker. There are other measures, as I have said, it's out of the scope of our pharmacology. Okay. يبدأ المهم what I should remember about the malignant hyperthermia, that dantrolene is the drug of a choice. Dantrolene should be always available in the surgical wards. One of the very important, لأن although the malignant hyperthermia is rare, لكن when it happens, it is fatal. So last words about the Xenon, the new gas, which is introduced into general anesthesia practice. Xenon, as you will see, it is a near ideal general anesthetic. Mostly it have very good property of a general anesthetic. except for few properties which doesn't have. First, it has no irritation to the respiratory tract. Axle ether, for example, does not produce irritation with respiratory tract, وبالتالي it does not produce laryngospasm. And it has very low blood gas partition coefficient وvery low oil water partition coefficient, وبالتالي we expect ان it has a very fast induction and very fast recovery as well. The MAC value is reasonable, about 60 to 70%. معناها in this case, if we use a mixture of 70% xenon and 30% oxygen, it will produce very good loss of consciousness. Produce loss of consciousness together with very strong analgesia and as well degree of muscle relaxation. Muscle relaxation is reasonable. Okay. They found that the xenon has nearly no effect at all on the vital functions like cardiovascular, respiratory, renal function. It has no effect at all on these organs, as not metabolized in the body as we see to toxic metabolites, and it is eliminated completely through the lungs. It's non-toxic, madam. There's no metabolites. There is no toxicity. Yeah, but what's the problem with xenon? It is expensive. It is still very expensive to make surgery with xenon. As well, we have to use a specific respiratory machines اللي هو يسموها closed circuit delivery system so that we can recycle the use of xenon. Okay. يبدأ xenon is near ideal general anesthetic. It's very good anesthetic except in it is still an expensive anesthetic. So lastly, we'll talk inshallah about the clinical use of inhalation anesthetic. The inhalation anesthetic, whether they are volatile liquid or gaseous anesthesia, they are used to maintain general anesthesia. And we have said that in this maintenance of general anesthesia is done by a mixture of nitrous oxide and halogenated hydrocarbon. Usually the induction of general anesthesia is done by intravenous general anesthetic, which we will talk about inshallah next presentation. So induction is done by intravenous general anesthetic, which will give very fast loss of consciousness. Then the general anesthesia is maintained by a mixture of nitrous oxide and halogenated hydrocarbon, influorine or sevoflurane or disflurane, whatever. And this include all surgical anesthesia like cesarean delivery, like cardiovascular surgery, neurosurgery, dental surgery, all types of general anesthesia. واضح كلام؟ يبدأ this is the very first important clinical use. Methoxyflurane is still used in trauma cases like in accidents or so. They are used by paramedics as analgesic. يبدأ في sometimes with accidents or whatever في trauma cases. Immediately the paramedics he needs a very strong analgesic, so they give methoxyflurane, some puffs of methoxyflurane, some inhalation of methoxyflurane, volatile liquid anesthetic. It will give very good analgesia till the patient arrives at the hospital. And then methoxyflurane, this is the only used. It is still used by paramedics in emergency to give good analgesic action. Okay. Isoflurane is used sometimes to induce general anesthesia in status epilepticus. في status epilepticus معناها continuous attack of epilepsy, which can cause damage to the brain. If other drugs are not effective, يعني status epilepticus becomes refractory, معناها it does not respond to the known anti-epileptic drugs, then the patient is placed under isoflurane to prevent damage to the brain. Okay, this is a clinical use of inhalation general anesthetic. So in summary, we have talked about a comparison between the different volatile general anesthetic in terms of their physical property, pharmacokinetic property, pharmacodynamic property, adverse drug reaction, and clinical use. Our next presentation, inshallah, will talk about the other groups of general anesthetics which are given through venous route, اللي هم intravenous general anesthetics. I would like to thank you very much for your attention. Hope to see you again in my next presentation. Stay well and in good health. والسلام عليكم ورحمة الله وبركاته. شكرا لكم على حسن الاستماع. الرجاء لا تنسوا الاشتراك في القناة، الإعجاب، التعليق والمشاركة مع الزملاء. دمتم بخير وعافية، والسلام عليكم ورحمة الله.